That can be part of it, so what you want. So if you're not able to make decisions, you've met with a lawyer ahead of time and said, or however you filled it out, and you said, these are my desires if I'm not able to make decisions for myself. It can be an extensive list. That's kind of the difference between a living will and an MDPOA, which you said what an MDPOA is, a power of attorney for healthcare decisions, is that rather than go through that huge laundry list of things, you have this person who knows what your wishes would be and will advocate for you if you're not able to do so. Good, what about a CPR directive? Has anybody heard of that before? So in the outpatient world, we have patients who don't want CPR, right? And so we tend to call these people the jewelry people. So they'll wear a bracelet or a necklace, a metal alert bracelet that says do not attempt resuscitation, okay? Just realize that that is an outpatient situation. If those patients come into the hospital, we need a DNR order. Okay, so that their directive applies inpatient as well. So in addition to whatever jewelry they have on, what else will they need? Purple bracelet, absolutely. Okay, so that goes into the DNR order. DNR orders are orders put in by physician or mid-level providers that specify patient wants CPR, doesn't want CPR, doesn't want intubation, doesn't want electricity. So it specifies that. That is good for this hospitalization only. It's a discrete incident. If the patient goes home and comes back tomorrow and still wants to be a DNR, needs another DNR order, okay? So just realize those orders are tied to each hospital admission. 5 wishes. You guys seen those? These are booklets. This is a national document that patients can use. You know, if you ask your patient, do you have an advance directive, and they say no, say, would you like some additional information? And they say yes, this is one of the options that you have to give your patient. It talks about end-of-life decision-making, and then it actually will walk them through some of those decisions. At the end, it does have a witness statement and how to sign it and make it like enact this, okay? These are available from chaplains, social workers. Some units just have them readily available. It depends on where you work. We also have, if you don't have a 5 wishes, we have a booklet called Your Right to Make Healthcare Decisions. This can also be given to patients who don't have an advance directive but are interested in additional information. This also walks them through the decision-making process, and then at the end it offers them the opportunity to complete an advance directive. Colorado MOST, or Medical Orders for Scope of Treatment. This is a form that crosses arenas of care. So this is valid for inpatient and outpatient. Okay, so this is, say, somebody partners with their primary care physician and says, I don't care if I'm outpatient or admitted, I never ever want to be coded, ever. And so they'll fill out this form, and obviously if we know about it, then we will abide by it. If you're in the outpatient world, these are some forms that you guys may be asked to help your patient complete. Realize when a patient comes in with this, if they come in with it, it is adequate for a DNR. They remain at do not resuscitate based on the Colorado MOST, okay? We have to scan it into Epic, and then it lives in the advanced directives section of their chart. Now, I will tell you from a practical standpoint, we typically will have a DNR order as well, just because it keeps things neat and tidy, and people are often more familiar with the DNR order versus the Colorado MOST. Okay. Questions about what's available as far as advanced directives are concerned? So when a patient is here, when they're admitted, they need to be screened on admission for an advanced directive. Find out what that is. In certain ambulatory clinics, it's part of the rooming guidelines about whether or not you screen your patients for advanced directives as well. If the inpatient doesn't have an MDPOA, they need to be asked, who would they like, if they're not able to make decisions, who would you like to make decisions for you? Every single patient if they don't have an MDPOA. And then you enter that person's name and phone number into the chart. Just type it in during your admission. Again, it's in the admission navigator, and that just clarifies about who is the medical power of attorney, medical proxy, and who can make decisions about visitation, okay? So what's the difference? An MDPOA, the patient has a paper to prove it. Again, this is a legal document that says, I appoint my brother Bill, and here's his contact information to make decisions for me if I'm not able to do that. If the patient has a living will, these things should agree, right? If it doesn't, then we need to find out which one he wants to next. A medical proxy is just the question that we've asked them. You don't have an MDPOA, who would you like us to call if you're not able to make decisions for yourself? Okay, the patient verbalized who they want, and then this can be argued, okay? Because it's not as hardcore as, say, a legal document. In the second booklet that I passed around, the little blue and green one, if you help your patient with this, a signature of a witness or notary is recommended but not required. And if they do fill it out, then you'll need to make a copy of it and send it down to the advanced directive people, and we'll talk about that process in just a second. Because we can only follow things that we know about, right? We don't have ESP. So those are the two things that were available. We talked about that already. The 5 wishes does need signatures of 2 witnesses or a notary. Okay, and as UCH folks, you shouldn't be witnessing documents like this for your patients. But there are some folks who have their notary public that are willing to provide that service to the patients as long as they're not providing direct care to them. All right, if a patient brings in, so this is how it gets from your hand, from your patient's hand into the chart, because everything gets scanned into Epic. And this would be for outpatient folks as well. If a patient comes in and has an advanced directive, either a living will or an MDPOA, you need to make a copy of it and then give them back the original, put the copy into a basket. There's a basket on every inpatient unit that a woman comes by almost every day with her little wheelie basket, collects all the documents, takes it down to hospital information management, scans it into the patient's chart. Make sure you put a patient label on it, okay? For outpatient people, there's usually either a basket or an envelope somewhere in your clinic that, same thing, somebody gets it to hospital management or information management, and then it becomes a permanent part of the patient's chart. Unless, of course, the patient revokes it, right? So semi-permanent. You guys will find out how to review that in Epic under code status tomorrow. In Colorado, who's not from Colorado? Okay, you guys are the only ones who can play. If you're from Colorado, you can't play. Who becomes the designated medical decision maker if the patient is not able to? What do you guys think? Just shout out answers. Spouse? Spouse? Any of the above. Okay. In Colorado, there is not a hierarchy of decision making. So it can be anybody. So if I'm hospitalized and my husband is like, I want to make decisions, my neighbor can be like, oh no, I want to make decisions. So, and they have to be given equal weight under the law. So just realize that's why we really like it when people come to us with documents in hand, because it simplifies things. That's why it becomes very, very important if somebody is able to name somebody on admission. It's not as strong as, say, an MDPOA or a living will, but it's better than an argument between interested parties, right? So if there's conflict or disagreement about how this works. So staff, meaning RN, MD, social work, tries to get everybody together at the table to have a conversation about who the appropriate person to make medical decisions for this patient is. Typically that works. Typically there's not an issue. Everybody comes to agreement. Obviously my neighbor is not going to trump my husband in that situation. And so this is a great place to go back to that ethical conversation about enlisting like social work, patient rep, spiritual care. They do a really nice job of sort of sorting out those issues. If they really can't agree, we can suggest to them who we feel like the appropriate person would be. And then if they really, really can't agree, then social work can help start the guardianship process. But I've seen that happen maybe a handful of times. People typically play nice in the sandbox most of the time. True or false, a patient can verbally revoke an advance directive at any time. That is true. So that's part of our patient family-centered care. It's kind of a standard practice in most hospitals is that, you know, even verbally somebody can say, I don't want that to work anymore. You just need to contact hospital medical records and tell them what's happened, and they'll give you the steps on how to undo that from the medical record. True or false? A DNR can be kept in place for surgery. False? Any truths? Okay, so it can be true. So back in 2012, we realized that we were suspending patients' DNR for surgery because we didn't want anybody to die in the OR, right? So who's that about? Is that about the patient or is that about the surgeon? That's about the surgeon. So we said, well, that doesn't really follow our patient family-centered care. So now we're gonna give the patient the option. If you come in from an outpatient with this Colorado Most, you don't wanna be coded, and now you're in the hospital and need surgery, is it reasonable for us to impose that you have to be a full code? We felt like it really wasn't, and our PFCC committee said it really wasn't. Now, is it reasonable, on the other hand, to ask for a surgery where you know you have to be paralyzed, sedated, and intubated, but you can't be intubated because you're a DNI? That doesn't make much sense either. So we have what's called goal-directed DNR. So it's usually time-specific and it's goal-directed. So what happens is if a patient is a DNR, and so they have a purple DNR band on, during their pre-op workup, it's called proceduralist, so that's either anesthesia or the person actually doing the procedure will cover that with the patient. Do you want to be a DNR? Do you not want to be a DNR? What are you okay with? So at this point, we can have patients going to the OR where they realize, okay, I'm going to be intubated for this procedure, and I'm fine with that, but if my heart stops while I'm on the table, don't code me. Don't shock me, don't give me drugs, don't do CPR. And that's totally okay, but then you'll need to write limitations on the armband. And everybody needs to be on the same page for what that time period is. So, is it just on the OR table? Is it from pre-op to PACU? Is it from OR to when the patient returns to his or her bed on the unit? So everybody just needs to be on the same page about that, and it's part of the it's part of the timeout during the procedure. If the proceduralist is not comfortable with what the patient's preferences are, we'll help the patient find another person to do the surgery, or maybe it's just not feasible to do the surgery at all. Any questions about that? Because that's a little bit different from other places. UCH staff can sign as a witness for advance directive if the patient or family asks for it. We kind of talked about this earlier. It's probably not a good idea. We kind of say false because it's a little bit of a conflict of interest if you're providing care to a patient and then signing legal documents that impact that care that you're providing. All right. And then again, some folks are notaries and provide those duties.
I have a question.
Yes.
So do you not normally have patients sign advance directives once they're admitted?
They can sign advance directives once they're admitted, but you just wouldn't be witnessing it.
So another different nurse that's not taking care of them, or who would witness?
Well, not a different nurse, but we encourage like other family members that, not their family members, but say maybe another visitor or something like that. It's just anybody who can attest to their